let's talk about antibiotics. This is going to be really cool, I hope, really cool discussion. I am going to group them and structure them for you, okay? So, first of all, on the first page for antibiotics in your lecture notes, there's a table which contains different discoveries associated with antibiotics. You don't need to know the dates, God forbid, but you have to be able to associate a name and what they did. Okay, so if I ask you, what did Alexander Fleming do? Discovered penicillin. What did Dorothy Hodgkin do? She identified the structure of penicillin. Am I clear? Zelman Waxman, what did he do? He discovered aminoglycosides such as streptomycin, neomycin, and actinomycin. Am I clear? Good? All right. So what are the general considerations for general ideas in the field of antibiotics? Source. Antibiotics can be natural, synthetic, or semi-synthetic. For quick examples, penicillin is a natural antibiotic. It was isolated from Penicillium notatum. That makes sense? Sulfonamides, like sulfa drugs. Are you familiar with Bactrim? The drug Bactrim, lucky you. It's the mix of sulfamethoxazole and trimethoprim, two synthetic antibiotics, fully synthetic, from scratch. Okay. Semi-synthetic, you take a natural antibiotic like penicillin, modify it, getting, say, methicillin, right? So original source is natural, but then it is chemically modified. Okay. Of course, you prefer cidal antibiotic, bactericidal, right, rather than static, but sometimes you don't have that option. Okay. Which one are you going to choose, broad or narrow spectrum? If you don't know what's going on with the patient, you want to use broad spectrum antibiotics. If you know exactly, so for instance, if you go for strep throat, you're going to use amoxicillin because it's a narrow spectrum antibiotic which will target gram-positives. So far, so good. Bioavailability. How are you going to administer antibiotic? Are you going to use oral or intravenous or intramuscular? Does that make sense? For instance, really good example. Are you familiar with amoxicillin? That's the drug that's prescribed for strep throat, right? So amoxicillin and ampicillin, two antibiotics that have very similar range of action. But ampicillin is not absorbed in the gut. So ampicillin, you want to use IM or IV. Amoxicillin, you can use orally. We clear so far? Good. Not a trivial question, resistance, okay? Do you expect the resistance, okay, from this microorganism? And finally, you need to watch out for superinfection. This is usually an effect of a broad spectrum antibiotic. Does that make sense? When you just do like a carpet bombing of a patient with some broad spectrum drug like ciprofloxacin, it will destroy everything and may result in a superinfection. So when pathogens suddenly start to, one good example from sort of clinical point of view, when women get treated for urinary tract infections, they usually get treated with a broad spectrum cephalosporins of the third generation. Make sense? Because it's not justified to wait till the clinical results come back from the lab, okay? So this broad spectrum antibiotics, they really wreak havoc in various microbiome, including vaginal microbiome. Without the control of normal vaginal microbiome, fungi start to grow. So this is your superinfection. So this is why when women get prescribed this broad spectrum cephalosporins, they also get an antifungal drug such as ketoconazole, miconazole, to just take it kind of prophylactically to prevent, say, I don't know, vaginal candidiasis. Does that make sense? Good? Questions? Okay.